In 1980, there was obstetrics, and the meaning of obstetrics for me was the smell of urine. Because all of the antenatal wards were completely full of women with the end of the bed lifted and the women receiving heparin because they were hospitalized for God knows what. And of course, because they were in bed rest, they were all receiving Clexane. And next to their bed, there was a big bottle full of urine, but the entrance to the bottle was very narrow, so most of the urine was outside. They were measuring histriol as a method of assessing fetal well-being. The method by which the size of the baby was being assessed is exactly the same as we do in England now, with a measuring tape or the CPC spandrel height to assess fetal growth and oxygenation. There was no such thing as fetal medicine. There was prenatal diagnosis. And there was prenatal diagnosis for three things. Amniocentesis, because the women were over the age of 35. Amniocentesis, because the second trimester maternal serum alpha-fetoprotein was increased, and they were having amniocentesis to measure acetylcholinesterase as a method of predicting whether the baby had spina bifida. And then, twice a week, we had two patients, one from Greece and one from Italy. They were coming for fetoscopy for the prenatal diagnosis of either thalassemia or hemophilia. That is prenatal diagnosis, no fetal medicine. And then the years went by, and then suddenly we introduced a new method of taking a blood sample from the babies by choriocentesis. And for me, it was a great liberation, because when we were doing fetoscopies, we all had to dress up, had to wear masks and gloves and gowns and feel extremely important as the nurse was tightening up our robes. It was the ultimate success of prenatal diagnosis. And I couldn't stand that because I had a passion for Marlborough that I could not tolerate being dressed up for more than half an hour. So then a big breakthrough for me was when I got rid of everything. I used to take a needle and put it inside the umbilical cord and take a blood sample. What had changed at that time is that we were beginning to realize that a lot of the fetal abnormalities were associated with chromosomal abnormalities. It was many years ago. And when we were doing an amniocentesis, it used to take 4 weeks before we could have the results of the karyotype. Whereas if we took a fetal blood sample and we looked at the lymphocytes, we could get the results in 48 hours. And that was, as far as I am concerned, the beginning of fetal medicine. We were on the 9th floor of a horrible building, King's, and we had 2 lifts, and most of the time the lifts were not working. It was good exercise for us. When we started taking a blood sample on the 9th floor, we used to send one of the fellows to the 8th floor. That was the labor ward. And there we had a blood gas machine, and that was the beginning of understanding of fetal physiology. We were measuring the oxygen levels as a method of assessing fetal oxygenation rather than relying on the smell of urine from the measurement of 24-hour urinary histriol. And I remember the first paper that we sent to the British Medical Journal at a time when there was a big fight, as has always been in historical terms, between obstetricians and neonatologists. The neonatologists were always complaining that the babies that they were mismanaging, they were asphyxiated at birth, was a consequence of mismanagement by the obstetricians. So it was a big moment for me when we realized that babies were hypoxic before they came anywhere near the labor on the ninth floor. And when we wrote a paper saying that there is such a thing as intrauterine fetal hypoxia, the journal rejected the paper because they said that in animal studies you cannot have chronic intrauterine hypoxia. When you induce hypoxia in an animal, you have a very rapid progression to acidemia and then they die. And I wrote back and I said, I was arrogant, as Paolo said. I said, thank God, unlike the editors of the journal, we are not rats. And he accepted the paper. And he showed, for the first time, that there is such a thing as chronic intrauterine hypoxia. And then we progressed to create a completely new field of fetal physiology. We demonstrated that babies that were small, not only were they hypoxic, but they were also starving. And a whole metabolic profile was created. But something else was happening at the same time. People like Katya were there, and Katya was obsessed with doing Doppler studies. When you do Doppler studies at that time, as a method of assessing fetal well-being, you have to look at the pregnancy outcome to validate the measurements of the Doppler. And there were so many things that happened between the assessment of the baby by Doppler and the birth of the baby. But by having the measurements of PO2, it was possible to correlate the results of all sorts of Doppler measurements with a PO2. So we moved along from prenatal diagnosis of hemophilia alitalia and thalassemia from Greece into the assessment of fetal physiology and defining an indirect way through Doppler what is the consequence of fetal hypoxia. At the same time, a very common condition, which is now very rarely seen, was that of red cell isoimmunization. In this condition, the maternal antibodies cross the placenta, they attach themselves into the fetal red cells, and then nothing much happens until about 16 to 17 weeks, where the fetal liver and spleen mature and they recognize the antibody-coated red cells as foreign bodies and they destroy them, and then the babies become anemic. Again, there was a secret about how to assess fetal anemia. It was the equivalent of having somebody that was involved in a car accident arriving in a casualty department, and instead of taking a blood sample to find out how much blood they had lost, we were taking photographs to see how much damage was done from the car accident. We were doing amniocentesis and measuring the yellowness of the amniotic fluid. Then suddenly, by having the ability to take a blood sample from the babies, we were able to assess directly the degree of fetal anemia, establish normal ranges of hemoglobin, define anemia, and correlate the results of the hemoglobin now concentration with the fetal Doppler measurements. That is what fetal medicine was doing to completely revolutionize the way we're thinking about obstetrics. And then in England, because the country was very poor, especially when you move from the south to the west and north, people were very poor, and a very common condition that we had was spina bifida. The way of trying to predict spina bifida is to take a blood sample at 16 weeks and measure the alpha-fetoprotein in the mother's blood. And that was what was happening throughout the country. And then the patients were sent to the obstetricians to do an amniocentesis. So the obstetricians were the technicians of the laboratory people, and they were telling them, do an amniocentesis to find out if the baby had spina bifida. We had a patient that came from Israel because the baby was at risk of Glanzmann's thrombasthenia. You don't know what it is, and neither do I. But it's a condition that affects the platelets. And the patient came for fetal blood sampling, and I scanned the baby, And I said, definitely, this baby has Glanzmann's thrombasthenia. And they asked me, but why do you think that the baby has Glanzmann's thrombasthenia? Well, Paulo said that I'm arrogant. I was arrogant, not anymore. And that is very sad. If I stop being arrogant, it means that I stop being useful. I noticed there was something strange about the baby's brain. And that is why I decided that the baby had Glanzmann's thrombasthenia. But of course, the next day when we had the results from the platelet function, the platelets were completely normal. So I was completely wrong. But I was struck by the fact there was something seriously wrong with the brain. A few days later, the woman had miscarried. That was useful because we could correlate the results of something looking bad about the brain and the miscarriage, and the baby had spina bifida. And therefore, the question was whether there was a relationship between the odd-looking head with spina bifida. And that was a case. So what we did is we had somebody look at all of the notes of patients that we had previously seen with spina bifida, and then we realized that all of the babies that had spina bifida had a lemon-shaped head and a banana-shaped cerebellum. And that was the beginning of a new era in fetal medicine, where you don't really need to be absolutely brilliant, like my teacher, Professor Campbell, in examining each segment of the spine. I smoked very heavily. I did not have the energy to sit around and look at each segment of the spine. Whereas looking at the head, it was quick enough for me to go and have another 2 cigarettes before I came back. And therefore, we were very happy for that. But, and this is what is very important in our field, the Royal College of Obstetricians and Gynecologists stopped inviting me to give any lectures at all, because they insisted that the method of screening for spina bifida is to do alpha-fetoprotein and amniocentesis. And the year was 1986. You would have thought that people would have jumped on this, but the obstetricians involved in prenatal diagnosis became the enemies of the people, as they often do. And that was England. In the United States of America, the change from the measurement of alpha-fetoprotein to looking at the head of the baby was 20 years later. So that was another thing that was happening in the 1980s. Also in the 1980s, we demonstrated that being obstetricians, being surgeons, we were macho. And the first thing that we would do, if we found something that looked odd, is to put needles inside the uterus. And one of the things that we noticed is that sometimes the babies have extra fluid in the lungs, or they have a collection of fluid in the bladder, or a collection of fluid in the head. So it was the era when we were putting little plastic tubes to drain the pleural effusions, to drain urinary tract, and also the brain. Very soon after the mid-80s, people realized that it was not a very clever idea to keep putting shunts in the brain of babies with hollow prosencephaly, because they were not being cured of the severe brain damage. In the case of pleural effusions, however, it became very obvious that that was very, very useful, and it has remained a very useful way of treating these babies. In the case of obstructive uropathy, it is tragic for us as a profession that 45 years later, we have not had the decency of carrying out one trial to see whether putting in shunts was useful or not. And then the years went by. We arrived in the 1990s. And then, in the context of red cell immunization, something strange happened. We had a woman, her name is Cherry Rooms. She has a boy who is very good in ballet, and his name is Kypros, God forgive me. And she came for an ultrasound scan because she had several babies that had died from red cell isoimmunization. And I was certain that you don't die from this condition before 16 weeks because you need the fetal reticulum and the fetal system to mature to destroy the antibody-coated red cells. But we saw this woman at 12 weeks, and the baby had a lot of fluid behind the neck. These are the perfect images of 1992. I then felt that that was extraordinary. How could this baby be hydropic against all of my teaching of the previous 10 years? What we were doing at the time was a trial between amniocentesis and chorionic villus sampling at 11 weeks. And the reason why we were doing this trial is because we realized that if you did a CVS very early on in pregnancy, the babies could end up being born without arms and fingers and so on. So we thought that maybe it's a good idea to go back to moving amniocentesis from 16 weeks to an earlier gestation. Exactly because we were doing that trial, in this case, this poor woman that had aged after several previous deaths, we had a result from karyotyping within 48 hours of seeing this collection of fluid. The baby had Down syndrome. At that time, there was a lot of interest amongst journalists about this new field of fetal medicine. There was a very attractive woman from Scotland that came to see me, and exactly because she was attractive, I asked her to come with me to a kebab house. I took her for lunch. She asked me, "What can you tell me?" I said, "I don't really know, but this is what we saw last week. And I think that the baby may have Down syndrome because it has this extra fluid behind the neck, and that may be a sign that there may be a chromosomal abnormality." So she said, "So what are you going to do?" I looked at her, I smiled, and I wanted to seduce her. They said, "Of course, we need to prove it." She said, "But how are you going to prove it?" I said, "We need to examine 30,000 pregnancies." That was a consequence of extensive scientific assessment and power calculations in my head in the kebab house. She said, "How are you going to find out these 30,000 patients?" Well, I said, "It depends on you." And that Sunday, in the Times, there was a photograph like that. And we said, "Women come." We're on the 9th floor. And 100,000 women came because we are open every day, every night, every weekend to validate the association between nuclear translucency and chromosomal abnormalities. And the years went by, and of course, now the best way of identifying pregnancies at risk of chromosomal abnormalities is to do cell-free DNA testing. But who should have this cell-free DNA test? If you're in a civilized society or a rich society, or the women are rich, they will pay for it and they will have it done. If you are in a poor country who would rather invest in nuclear weapons and missiles in a destructive way against the human race, like England, you offer the new test only to the women that have a risk from first trimester screening with a combined test of 1 in 100. But if you offer the test to those with a risk of 1 in 100, the detection rate is only 80%. So the consequence of the major breakthrough in screening for chromosomal abnormalities from the first trimester combined test, where with a screen positive rate of 5%, you have a detection rate of 90%, because we are in a poor country that invests in killing people rather than saving people, is to reduce the detection rate from 90 to 80%. Of course, another thing that had happened is that we realized that when you look at the back of the neck, you may also realize that there may be various problems in the baby. And an era evolved where the first trimester scan became the first anomaly scan. So the vast majority of the major fetal abnormalities are detected now in the first trimester of pregnancy. The year is 1992, but the year now is 2026. Last week, in one of the hospitals where I sent doctors to do scans, I was informed by the National Screening Committee that we are not allowed to do a fetal anomaly scan in the first trimester because the Central Committee of this governmental organization has decided that the nuclear transfusion is scam, so screening for Downs, and that's all you need to do. You must not examine the baby for any fetal abnormalities. Also, if you have a high nuclear transfusion, which is a marker of cardiac defects, papers from Bari showing that 75% of the cardiac defects can be detected in the first trimester, if the woman does not want to have screening for Downs, you must not measure the nuclear transfusion. It's against the rules of the Central Committee of the British democracy not to examine the baby, not to measure the nuclear transfusion. So on the one side you have scientific advances, and on the other half you have arteriosclerotic institutions that stand against the progress, because these institutions are the enemies of the people. And then the years get more exciting. By 1992, we were having women come with polyhydramnios. And the best thing we could do is drain the amniotic fluid and watch the babies die, or worse, be born and be severely handicapped. And we decided at that time that perhaps what you could do is try to interfere with the pathophysiology of the condition by introducing an endoscope in the uterus and using laser to separate them. And that's one of the photographs from those days. Again, I was allergic to masks and gloves and gowns. So, very important people there. The one that looks like Kaiser on the back is Kurt Hecker, who became a major fetal surgeon in Germany, and he retired last year. And the one that is bending forwards is Yves, the most important fetal surgeon in Spain. In Italy, in France. I have not become part of the system, Paolo, but my brain doesn't work so well anymore. And then another thing that was happening in the 2000s was the issue of diaphragmatic hernia, where Jan de Prest was doing a lot of animal experiments in Belgium and demonstrating that perhaps one of the approaches to improve the condition of these babies was to put a balloon in the throat of these animals. They were very reluctant to move into fetal surgery. So there was a Mrs. Sophocleus. Sophocleus is a 47-year-old Cypriot woman with many years of infertility, who is eventually diagnosed with a baby with diaphragmatic hernia. And they told her that there's a guy in England. They either call me great or crazy. It's a crazy guy in England that perhaps can do something about it. Every other day I receive a phone call at 6 o'clock in the morning. In Cyprus it's 8 by that time, and they always pretend that they don't know the time difference. And they usually ask me about the menopause, about fibroids, about psychological problems, and there's a lot of psychological problems in the Middle East, especially now, thanks to American democratic desires to kill as many people and exterminate as many civilizations as they can possibly do, because they come from a country that does not have any civilization. Again, today, I was reading in the news that the psychopathic president of free democracy is threatening to eliminate a civilization of 3,000 years because he comes from a country that has no civilization beyond 200 years. So Sophocles came to England to have an idea of what he could do. So I told Jan, you can carry on for the rest of your life killing rats and rabbits. I asked him whether he actually eats the rabbits after the operation. He said, no, we don't. I said, okay, unless you come to London next week and we do this operation on Mr. Sophocleus, I'm going to do it myself. So he came. And we decided that we should do the operation at a time where if things were to go wrong, the baby could at least survive by being delivered. So it shows a gestation age of 34 weeks, which of course was completely stupid because we knew from the animal studies that if we wanted to improve the condition of the baby, we should do the operation at 26 weeks. But what we learned from that operation is that nobody died. It was very easy, it was successful, but the patient, of course, the baby died because it was too late for this intervention. Again, it's amazing really how things evolve, how you make shortcuts in deciding what are the next steps. But the most important thing is that you need to try the next step, otherwise you don't advance. So the years went by and it took another 20 years after Mrs. Sophocleus to develop the technique, to do a trial and prove that this is effective. And then we come again to the 2000s. And there, what else do we have? The leading cause of death and handicap in obstetrics is preterm birth. In England, you are not allowed to measure the cervical length. That's shown 20 years ago that if you measure the cervical length, you can identify women where the cervix is opening up, and perhaps if you give them progesterone or if you stitch up the cervix, you can prevent, to a certain extent, preterm birth. We are not allowed to do cervical length, and the reason for that is what they call equity. Equity is fascism. It's fascism by institutions where they, in the name of equality, they want to suppress everybody to the lowest possible denominator. They are the enemies of excellence. And they use these politically correct terminologies that are against the people. We have known for many years that preterm birth is a cause of death. We have known for many years that more than 1 million babies die in the world because of this condition, but the rate of preterm birth has not changed in the last 50 years. And one of the countries in the world with the highest rate of preterm birth is the country that has the highest number of investment in nuclear, biological, and chemical weapons, the United States of America. And what is becoming very clear in our minds, it is wrong to be talking about preterm birth as an event that happens before 37 weeks. Because what causes death and handicap is birth before 33 weeks. If we screen by measuring the cervical length on everybody at the time of the 20-week scan, we will identify 60 to 70% of the women that will subsequently deliver before 33 weeks. Not good at all in predicting an irrelevant endpoint called preterm birth before 37 weeks. And what do you do when you find that the cervix is short? Well, you can put in a stitch, you can give them progesterone, and you can put a pessary around the cervix. And then it takes 20 years of repeated trials to find out which one of these methods is effective. It is very clear that progesterone is effective, and if you see these women given progesterone and then 1 week or 2 later the cervix continues to shorten, then you can put in a stitch. And then one of the main causes of death in obstetrics, more than 75,000 women die every year in the world, is preeclampsia. In England, in the United States, and other primitive societies, the way by which you assess whether somebody is at risk of developing preeclampsia is to ask them a few questions. And we have known for many years that these questions will identify the minority of patients that will develop preeclampsia. If instead of asking a few questions, you also take a Doppler measurement of the uterine outputs at 12 weeks, and now, instead of that, a simpler measurement of the ophthalmic artery Doppler, and you measure placental growth factor, then you can identify twice as many of those that will deliver with preeclampsia. You can identify 90% of the women that will develop preeclampsia requiring delivery before 32 weeks, which is the main cause of death in relation to preeclampsia. And if you give them an exceptionally expensive medication, like aspirin, if there was some other drug by some pharmaceutical company for which you had to pay £1,000, most probably it would be implemented, but because it's aspirin, then major resistance in England and worse in the United States about implementing a proper method of screening and prevention of one of the leading causes of death for women. The enemies of the people are within the institutions. And then we come towards the end of the lecture. Small babies, one of the main associations with fetal death. Well, there are 3 types of small babies. The small babies that are born before 32 weeks, the vast majority of those babies are associated with preeclampsia, and those that are not associated with preeclampsia have the same biomarkers as those of early preeclampsia. So by properly screening for preeclampsia, giving this with an aspirin, you are eliminating one of the major causes of stillbirth in small gestational babies. The biggest challenge, however, is the majority of the small babies that come after 37 weeks. In England, the United States, and other primitive societies, the way of assessing growth and fetal oxygenation is to measure the symphysis fundal height. And every year, there are major courses undertaken to explain to people how to find the symphysis and how to feel for the fundus. This is the way of assessing fetal growth. The good news is that there is going to be very, very soon, within a year from now, a new approach that will require a completely new type of a workforce. We will get rid of midwives. We will get rid of all of those people that have resisted any change. Because with AI, and you'll hear a lot more about that later on, you can get the cleaner of the hospital. The cleaner, not the nurse, the cleaners. And you tell her, take this thing and do 1, 2, 3, 4, 5, 6, and that within seconds will tell you what is the estimated fetal weight. We get rid of the measuring tapes, give it back to the tailors to make nice clothes for us, and bring in a new type of a workforce. The 700,000 victims of the British universities. In England, the universities have become football clubs. They make money by inventing new courses. And they charge people a lot of money. And there are 700,000 university graduates that come out of the university with a debt of 50 to 70,000 pounds that will never get a job. They will never get a job. They're 21 years old, and they will be unemployed forever, and they will have a debt at the back of their neck for the rest of their life. That is a new workforce that will take on these technologies and progress with them if the ones that now control the power allow it. I keep mentioning this because on the one hand, you have scientific advances, on the other hand, you have institutions that are the enemies of the people that stop progress in many aspects of medicine at least. And then finally, stillbirth. Well, there's no such thing as stillbirth. The babies die for all sorts of reasons. And the ones that die early are the ones that die because of placental insufficiency that can be predicted and prevented by giving aspirin if we bother to screen them properly. And the ones that die late are problematic. I hope that with AI, again, in addition to assessing the fetal size, we will be more efficiently be able to do so by using AI. Finally, in this slide, I show that for many, many years, when you hear lectures in obstetrics about diabetes, about preeclampsia, the people take their handkerchief out of their pockets and they start crying. They cry very much because they say, if you develop gestational diabetes, if you develop preeclampsia, you're going to suffer. God doesn't love you. You're going to die in 10, 20 years as a consequence of cardiovascular disease. And then we finish the lecture, and then after 10 years we repeat the lecture, and 20 years we repeat the lecture, and everybody always cries at the end of the process. However, whose responsibility is it to assess these women? Because what we have found, if we now bring in as part of obstetric fetal medicine type of care, a postnatal clinic, not at the silly 6 weeks, but at 6 months after birth, then we will find out that a lot of the women that have had gestational diabetes, they don't only have dysglycemia, they have dyslipidemia, they have cardiac dysfunction, they have renal dysfunction, and they have hepatic dysfunction. And the other way around, a lot of the women that have had preeclampsia, not only do they have hypertensive disease, but many other cardiometabolic abnormalities that are obvious from the 6th month postnatal. I will finish. In 1929, a nice lawyer in England, under pressure from a group of terrorist women, the suffragettes, that were demanding the vote for women, but they also realized that the vote is meaningless on its own unless it is accompanied by social reforms. They demanded the vote for women, and they demanded that there should be routine antenatal care for all. Under this pressure, the government in England introduced a model of care which is being followed up throughout the world 100 years later. According to this model, we need to see the women increasingly, more commonly, as the pregnancy progresses, because many of the pregnancy complications occur at the end. This is the model that I refer to as the headless chicken. It's a model where you try to diagnose the problems after they happen and you try to patch them up. And then I feel that the time has come, that the model is inverted in a new pyramid of care where the main emphasis in pregnancy care derived from fetal medicine, redefining what is obstetrics, is to screen for as many pregnancy complications in the beginning and develop strategies to prevent these complications. You've had enough. Thank you.